Week one's case from lab. We had a 23-year-old male with ankle pain. Recapping some of the history, it was anterolateral ankle pain, dull and achy in nature that became sharp with movements. He twisted his ankles 3 days ago playing tennis. Walking and standing made it worse. Rest and the use of Advil seemed to help. And the pain is kind of intermittent, but he does have it every day. He had denied any previous ankle pain, trauma, hospitalization, surgeries. He did take some Claritin as well as Advil for the pain. His effect on daily life and activities of daily living is the patient's ability to get dressed, bathe, and groom themselves. He was able to get dressed and go to school, though his activities were limited, but he could care for himself. When we look at extended activities of daily living, that is anything else in their lifestyle that they would want to do, but are unable to, and he can't do much because of the pain. He feels it is not limiting him from any specific activity, it is just slowing him down. Occupationally, he is a full-time undergraduate student, and the chief complaint does not alter his ability to perform his duties at school. When we look at a focused review of systems, we need to first of all figure out what body systems can be generating the primary symptom, and or any other symptoms involved with the injury. So when we look at injuries, especially in the peripheral injuries, we have to be concerned about musculoskeletal as well as vascular and neurologic. So when we look at a vascular issue, we are looking for damage in macro vessels, not necessarily micro vessels associated with bruising and swelling, but significant macro vessel involvement, fibular artery, popliteal artery, etc. If so, the patient may have coldness in the distal extremity. They may have some color changes in the distal extremity. It may be pale, may be blue, may be red. When we ask the patient these questions, we need to ask them, do they notice is one foot warmer or colder? Do they notice that one foot is more pale, more blue, more red than the other side? Asking them if they've had any color changes or temperature changes is too vague for the average patient to understand. We also want to look at swelling at the joint involved and or in the distal extremity. Neurologically, is there any tingling, any numbness, any weakness present? The patient may have some weakness secondary to pain, but we are looking for true neurological weakness. And then in the musculoskeletal system, we need to figure out are there other joints in the kinetic chain involved? Can the patient weight bear? When we look at some of the other categories of data, family and social in this case are non-contributory. His family history is not going to change the mechanism of injury. His social history is not going to change the mechanism. Therefore, those questions really don't need to be asked in a focused interview. However, in clinic, you'll be doing focused interviews with then following up with family, social, and all other biopsychosocial issues that need to be documented in the clinical file. So when we look at our initial clinical impression we spoke about in lab, it was the fact that we could have been dealing with a sprain of the anterior talofibular ligament, which is the most often involved. Or the calcaneofibular ligament is the second most common. The third is the posterior talofibular ligament, although this is least likely because it is the strongest ligament. We also looked at we could be dealing with a fracture, possibly of the talus, and less likely of the distal fibula. There could also be a tendinopathy of the peroneus longus and brevis tendons. As the images are demonstrating here, this image here demonstrates what a talar dome fracture or talar dome compression fracture would look like. Remember, I spoke about in lab with an inversion ankle sprain, the tibia and the talus will line up on top of each other, and when the patient's body weight drops through the tibial shaft, we have the potential to end up with a compression fracture. So in our physical exam, the first thing we are inspecting for is whether or not the patient can walk. Do they have normal gait patterns? Can they ambulate? Can they weight bear? Then we want to look for any redness or swelling. That could start to indicate maybe we have a tear of a ligament. If we have any bruising, it could indicate a grade 2 or greater 3 sprain or a fracture. So as we start to look at the foot to help identify whether or not we can identify whether there is swelling, we want to look for normal landmarks. Can we see the malleoli? Can we see the tendons? The extensor hallucis longus tendon, extensor digitorum longus tendon. When we go to the other foot, we start to lose some of the normal contour, which is indicating that we have some subcutaneous swelling associated with it. As we look at some of the other images, we'll notice great bruising, distal into the hind foot. We want to look at movement. Can the patient ambulate? Ambulation is the quantity of movement. Do they have the ability to walk or move about? Gait, however, is the quality of movement. What is the manner of their walking, and are there pathological patterns present, which we will talk about more as the quarter unfolds, looking for a spastic gait, as we might see with an upper motor neuron lesion like a stroke, some sort of scissoring gait, a propulsive gait like someone who might have Parkinson's disease, a steppage or slappage gait like someone who might have a sensory involvement, diabetic neuropathy, or a dorsal columns lesion, or some sort of waddling gait. We'll then work on palpating both soft tissue and bony. You need to palpate the entire foot and ankle, but want to pay special attention to the items on our differential list: the anterior talofibular ligament, peroneus longus and brevis, possibly peroneus tertius tendons, the lateral malleolus, the talus, the fourth and fifth metatarsals, styloid processes, and the base of the fourth and fifth. In the file, under palpation, we need to document if there is any pain, swelling, redness, temperature changes in terms of the site, what the quality would be, and if so, how severe is the pain on the areas that we may find. Remember, with palpation, the purpose is to detect abnormal tissue texture. We want to evaluate for symmetry. We want to detect and assess range of motions. We want to palpate for tenderness, identify any temperature changes, and identify any masses. So with palpation, there are some tips and tricks. 1, breathe as you're doing this. Go very slow. Be receptive to feedback from the patient. And as you're practicing, be receptive to feedback from your fellow classmate. Be soft and sensitive, remembering that you are working with a patient who is symptomatic. You are used to palpating each other, which are asymptomatic individuals. As you start to work with symptomatic patients, you are going to have to be more deliberate in your technique. You want to move the tissue, make circles as you palpate. We don't want you to be pizza poking like you're pushing into pizza dough, or squeezing, or finger walking. So as we move into range of motion, we're going to look at active and passive range of motion, remembering the ranges and the normal motions. And in the file, you will document as to why the motion cannot be accomplished. Is it due to pain? Is it due to the fact that they have a bony block? Maybe there's an osteochondral fragment that has released that is keeping them from going into full range of motion. Or is there weakness because of some muscular contraction? So we look at the orthopedic testing. We want to start with drawer sign. And it'll be documented in the clinical file, not just positive or negative. But if the test is positive, you need to identify where the site, the quality, and the severity of the positive finding would be. For an example, in drawer sign, ankle drawer produced sharp pain over the lateral ankle. You could be more specific to say lateral malleolus. It was rated at a 5 out of 10, and we noted gapping and anterior translation of the tibia, the talus on the tibia. O'Donoghue's could also be done in this case. Looking at, and in this case, O'Donoghue's, there was sharp pain. It was noted on the lateral side of the ankle with passive range of motion of inversion and eversion, and it was graded at a 5 out of 10. So when we also need to look at possible neurologic involvement, evaluating if there is any sensory involvement due to a peripheral nerve lesion and not a spinal nerve lesion. Looking to see if there is any motor. Now, if the patient has instability, we will not be able to assess generally their motor strength on that first visit, but in subsequent visits you would want to be able to evaluate those. And looking for a reflex if there is a reflex associated with a peripheral nerve pattern. We are looking for sensory changes in any true neurological weakness and not just weakness secondary to pain. Instrumentation could be done. We could use a tuning fork. The tuning fork is going to assess for any periosteal disruption, whether there's a fracture or a bone bruise or a contusion. So if it is positive, it indicates a suspected fracture if the patient has significant amount of pain. If it is negative, it does not necessarily give us any diagnostic information, meaning a negative test does not preclude the possibility of a fracture. Because using a tuning fork is not sensitive enough to pick up 100% of all fractures, the patient could have a hairline fracture that it would not be able to identify. We might think about radiology after having done our physical exam, and films are going to be ordered based on the history, mechanism, quality, ADL restrictions. There are guidelines in the radiology handbook that will help you identify whether or not you need to order a film. We will take our physical exam findings. And also, in this case, if the patient has the ability to weight bear, if there is tenderness and where that tenderness might be, and any positive orthopedic tests, assuming the patient was even able to perform any of them. There's something known as the Ottawa Rules for Radiology, and that is going to help you identify the need for films. You will, as you work through the curriculum, need to know all of the rules for Ottawa ankle rules. In this quarter, in 7th quarter, I just need you to know that Ottawa is for radiographic, the need for radiographs of the foot and ankle. And it basically works on the physical exam findings. Do we have bone tenderness at A, the posterior tip of the lateral malleolus? Do they have any tenderness at B, of the posterior edge or tip of the malleolus? And is there inability to both weight bear immediately and or in the emergency department? Because Ottawa rules generally have been used more emergent care. So that is when you would need to do an ankle series. A foot series would be required only if there's pain in the midfoot and any of the zones at, say, the base of the 5th metatarsal or at the navicular, whether we're dealing with an inversion or eversion ankle sprain. So remember your ABCs when you're looking at films. Look for the alignment, look at the bone, look at the cortices, look for the cartilage, as well as the soft tissue. So when we look at these slides, we have slide A and B. Can you identify the slide with the pathology? Use your ABCs to be able to identify this. So after having reviewed it, you should see that the slide with the pathology is slide B.